Hello, and welcome to today's webinar, The Business Principles of Healthy Palliative Care Programs. I'm your moderator, Holly Vossel, Senior Reporter for Hospice News and Palliative Care News. Before we begin, a really big thanks to our sponsors for helping to make this Hospice News webinar possible. Much gratitude to Data Sharks and CHAP, Community Health Accreditation Partners. Next, we have just a few notes to cover. A link to today's webinar will be emailed to registrants, and we'll also make it available on demand recording on our Hospice News virtual event website, so check back there. And attendees will notice like a main menu icon at the top of your screens there. That's for both our live and on-demand viewers that you can click in there and use the Ask Questions widget at any time to submit questions for our speakers, which I see we have a few here already, which is great. We'll try to address these either as they're applicable or in our Q&A session later on. So next, we also have this resources widget, which you can use to download today's PowerPoint slides and any other materials. Throughout the webinar, you can kind of expand or view these slides using that diagonal arrow at the top right. Okay, and you can also use that reactions widget to kind of interact with us, submit your feedback as we go along here. And just lastly, if you have any technical difficulties, we first try that good refresh of your internet browser. If that doesn't work, just reach out to us using the help button, or you can use the Q&A widget to kind of engage with our team and help you out there. All right, so without further ado, let's move on to introduce our presenters today. We have Bill Taylor, he's president of Data Sharks. We also have Shane LeQuire, which is the senior growth consultant at CHAP. So thank you so much for delving into this business of palliative care. I think, Bill, you're going to get our discussion started today, so take it away from here.
I will do that. All right. Just a little more intro, if you don't mind, because I want to tell people what I do, but I also want people to really hear what Shane does. So, yes, I'm a CPA, and I've been in hospice for many years. I learned hospice from the great Andrew Reed at MVI, where I spent many years. But I also learned hospice by going into dozens and dozens of hospice organizations. My job was to help them with profitability. My job was to help them with quality. I'm always comfortable in walking into a hospice that's financially underwater and helping them turn around. That's always been meaningful to me. The other part of what I do is cost reports. Last April, I processed my 1,000th cost report. And I love doing cost reports. Hospice News put out this thing of the top 50 hospice organizations or chains or something about 3 or 4 months ago, and you know what I do. I look how many of them did I do cost reports for? There were 7, none in the top 5, but there were 7. So I really like doing that. So I want Shane to tell you what he does too, really quickly, because I have brought Shane's group into 4 hospices that I was working with. I brought them in because they work. And out of those 4, I think we've been successful in 3 of them. One of them, I love those people dearly, Shane, but they just weren't ready for it. So Shane, talk to them just a minute about what you do.
Absolutely. Thanks, Bill. Yeah, Shane LeQuire. I'm a senior growth consultant with CHAP. We have an arm of CHAP called CHAP Growth Solutions. And so outside of accreditation, we help with, anything from territory optimization to helping organizations come up with processes for palliative care, as we're going to talk about today. Prior to CHAP, I have been in hospice now for 17 years, 17 of those as a sales leader, some operations as well, but I've led teams as large as 95 salespeople, 7 area vice presidents, covered about 27 states in my career. So, I've seen multiple, how hospice can be really good and where there's opportunities to grow. And so, really we'll bring some of that experience today as we talk about how we can help support your growth. Thanks, Bill.
Okay. So I want to start with, you always start with what I learned at the very beginning in my hospice world. Always start at the patient level. We called it the patient family chair. Always start with care first. Palliative first is about care, then about the business. Now that said, today's webinar is more about the business than about the actual care. Actual care, there are so many good experts out there. I bet some of you are some of those experts. I strongly believe in what is taught by Dr. Cameron Cameron Mueller and by Dr. John Morris over in Hendersonville, North Carolina. I love what they teach about the care first model of palliative. But this webinar is about integrating the palliative care into a hospice program, with enough resources so that you can do these three things. So you can deliver a positive patient experience. Underline that, a positive patient experience. At the end of the day, palliative, I know, it's a specialized medical care, for people with serious illnesses. And we have the ability, the strength, the knowledge to make this path for them much better, much simpler, much easier. So always start with the patient care experience. Then we want to be able to provide sound clinical care. I've seen so many different palliative models, and I know, being in so many hospices, I've seen the nurse only. I've seen the nurse and nurse practitioner only. I've seen the physician-led. I've seen the social worker only. So many different models that we can call palliative care right now. And we develop our models based on several things, some of which are, what can we build? And that's valid. It is. But I think there's so much more to the clinical care that we can bring to it. And we will explore some of those things that help us with the clinical care piece, but also, okay, some of the moves we make also help us from a business or growth perspective. And what we'll focus on most today is delivering on our agency business objectives. Your hospice people, I presume you're hospice people. You start a palliative program because missionally you feel like it's the right thing to do from a business perspective, because you believe it can bring you eligible hospice patients sooner. I've been in so many agencies where the palliative program was not delivering on that. They might have been delivering on their promise to the patient, bless them, but not on the business objectives. Sometimes you'll find that palliative care programs hold on to their patients too long. Your nurses, your MPs, your social workers, your physicians, you get attached to your patients and you don't want to let them go. Well, we're going to talk about some of those things today. Shane, you talk a little bit about some of our business side objectives.
Absolutely. So to your point, Bill, I think, every hospice that chooses to start a palliative care or they find themselves in palliative care, those original goals are you want to attract eligible hospice patients that are further upstream. Unfortunately, and what we see so many times is the growth of the palliative program outpaces the hospice. And what you end up doing is having two separate siloed businesses that you're trying to manage. And unfortunately, it pulls away from what the original mission was when you started that, is to attract eligible hospice patients sooner. Two, you really want to try to attract a longer length of stay to the agency. If you look statistically, NHPCO, about 49% of eligible patients are utilizing the hospice benefit. So, every one patient that is dying with hospice, you've got one that's dying without hospice. And then if you look at the median length of stay, nationally is about 18 days. So, you're only using a tenth of that hospice benefit. So ideally, if you're starting a palliative care program, it would be to attract patients sooner, get them on sooner, eligible patients, and that ultimately will help your length of stay. Another really big strategy that a lot of reasons we start palliative care programs is we want to create a barrier to other hospice agencies, so they're not taking our patients. In 2022, there was just over 5,800 hospices serving patients in the United States. That number has grown dramatically in my 17 years in hospice, and about 75% of those were for-profit businesses. So these for-profit hospices are out there, with the mind of growing and growth first. So, it's very important that if we're creating a palliative care program, that we're going to access our patients and protect our patients that we have and get them on our services versus going to someone else's services. And then lastly, just to lean into those statistics, we want to deepen our relationships with our referral sources. Clearly, we struggle as an industry to identify patients soon enough for hospice. So a really, really good palliative program is going to help, one, educate our referral sources on earlier identification, but also create a great space for patients to age in place, be on services longer, and get the timeliness of care at a hospice that they need. You can go to the next slide. So, and Bill and I have had some good, healthy debates on this next topic, but, what makes a good palliative leader? As Bill mentioned, we've worked with about 4 together. I've worked with several other palliative programs in my career. Who should be the leader? Should it be a physician? Does it need to be a nurse? It can be. I historically have seen, most programs are led by either a medical director or a nurse. But oftentimes, is that the right person? I think that's a question you have to ask yourself, is like, who do I need leading this? But I really do think at the end of the day, it's about leadership. It's like, who can lead this team in the right direction to give them, the guidance they need, to challenge on what eligibility looks like. First and foremost, having someone who is an expert on hospice eligibility. That is what we see as the biggest gap oftentimes, is you've got someone leading a program who doesn't really know what hospice eligible patients look like. They may be fantastic in a clinic setting of seeing patients and seeing large volumes of patients, but someone who knows eligibility, who knows the LCDs, who use, FAST score and, PPS and other tools to really determine eligibility. Another thing that I've seen with really, really strong leaders in palliative care is they're good teachers, and they invest teaching their palliative and clinical teams how to have good goals of care conversations. What does that look like at the bedside? Because that many times is a missing piece. And if the person leading that program isn't comfortable doing that, they may be in the wrong seat. Number 3, a need for speed. Again, this is a really big missing piece, and I think oftentimes is the result of having a lopsided palliative census versus hospice. But I've seen it to where it's taken 2 to 3 weeks to do a start of care on a new palliative consult. That's very dangerous and scary, because oftentimes patients that are referred to palliative care are hospice eligible. And, we should be screening for eligibility on every single palliative referral that comes through the door, because they very well may be qualified for hospice today. So just making sure that we're staffing ourselves, and Bill's going to go into this incredibly well in the next few slides, as far as how do we right size and have the right staffing model so we can provide, speed to care. We can get out there, because as it says, the first to the patient wins. And then the last one is really just having a grasp for numbers. You don't need to be an accountant like Bill, but you do need to understand, like, how do we drive activity through data? How do we utilize KPIs? How do we utilize the staffing tool that we're going to go over to really drive outcomes? Because oftentimes, and this is where sometimes it's a limitation in a clinical leader, is they may not be comfortable really utilizing numbers to drive outcomes. And I think that's going to be a big piece we'll talk through here in just a little bit.
Let's talk a little bit about the prime directives for this palliative business. Shane just mentioned it. Teach your leader the numbers. I want to say this because I want you to know. Some people will say, "Oh, but the leader of our palliative program is a nurse, and she's really not a number person." Let that go. I have worked with, oh goodness, hundreds of nurse managers. And here's what I've learned. Here's what I know. Here's what is the truth. Nurse managers get the financial side of hospice and palliative much faster than accountants will ever get the nursing side of hospice and palliative. They'll get the numbers. I will show you a tool in just a couple of minutes that I have taught to just so many nurse managers. They get it. In fact, you'll get it. When I show it to you, you'll say, "Oh yeah, that's how you do it. That's how it works." Here's some things I want, some numbers that mean something to you. Convert at least 15% of the average palliative census to hospice every month. Now, Shane has been in organizations where that number was 30%, where that was the expectation, that was the standard. I softened that a bit. I work with largely nonprofit hospices. I love most of my for-profit friends too, but I ask for about 15. You need 15 as your floor, 15% of your average palliative care. But I know how, and a lot of you are saying, well, we do way better than that. No, you're not reading this right. Conversion to some of you means, eventually 85% of our palliative patients are going to get to hospice. No, don't measure that. That's not a helpful measure. I want to know today, of your average palliative census today, I want 15% of those to convert to hospice this month. If it's not, then something's not happening right. We're not bringing in the right patient, or we don't really understand eligibility as much as we think we do. 2, set a cap on palliative losses. It's hard to walk into a hospice organization where the palliative program is losing 8%, not of palliative revenue, of hospice revenue. And that's how you want to measure it. You want to look at your palliative program. Forgive me, I'm looking at it through my cost accountant lens for just a minute. You want to look at your palliative program as another hospice expense, an expense to the mothership of hospice. And you can't let that expense to the hospice agency be more than 2% of the hospice net patient revenue. Now, there's several things you can do that will give you more headroom so that 2% doesn't arrive as quickly as you might. A handful of organizations I've worked with, they get regular grants from the hospital. They have deals with the hospital. We'll send you palliative patients. We'll give you grants for for your palliative program. But the palliative patients we send you, they better not get hospitalized. Okay, so it's a deal that is made with hospitals frequently as a grant. Never, third bullet point, never grow your palliative census larger than the number of patients your staff can see in a month. And most of you are thinking, well, that's kind of obvious. Is it? Run a report for me. Go back into your EMR, whatever it is you do for palliative. And by the way, if you find a good EMR for palliative, let me know. Go into it and see all the patients that you have and the number of visits they've had in the last month. Okay, most of them will have gotten a visit. Some won't have. I knew one hospice organization, their palliative program was double the size of the hospice. Their intentions were good. They were. But it got so big they couldn't go see the patients. They didn't have the staff. They couldn't afford the staff. You can't let your palliative program get so large that you can't go see the patients. It's not right, for one thing. Okay. Last, in this prime directive speech, you can't win without high visit production. Your people have to be out there making the visits. That they have to see, and every time they're out there, they're looking for eligibility. Yes, they are helping people, coordinating care and such, but they're looking for eligibility all the time with every visit, with every call. You're not going to win without production. It'll hurt you on the cost side. It will hurt you on the conversion side. And clinics help. Right now, I'm the interim CFO for Hines Hospice. Now it's Hines Life Care in Fresno, California. And so I'm talking to them about their very, very small palliative program. And we're talking about growing that. And I said, it really helps to have a clinic. And, I'm kind of new to that building, and they're all kind of looking at each other. And I said, what? And they said, our bottom floor. It's arranged just like a doctor's office, just like a clinic would be. And I'm thinking, guys, We got it here. Okay, I see questions. I got to answer some questions. What's the best DMR for palliative care? Yeah, Nancy Baldor? I don't know. Most of them will claim to be. I'm not in love with any of them. I've never seen one that really worked that well. Okay, how can you put a cap on your palliative census based on staffing limits without turning off and away your referral sources? That's a really good question. So you can't turn off those referral sources. Let me ask this question first. Are they giving you people that will be hospice eligible within, let me ask this, 6 months, a year? If not, I'm not sure that you're getting the right person, and I'm not sure, okay? What are the downfalls of not admitting hospice eligible patients to a palliative program? Or could that be something that works? I'm not quite sure, Jim, that I totally grasp the question. Some people use their palliative program because the referral sources don't want to have the talk, okay, with the patient, and so they send them to our palliative program, and we have the talk, and we have the talk. But sometimes we have a greater influence in the patients that we're going to get. And Samta, I want to address your question when I get to a little different spot in the presentation. Thank you. And if I missed your question, I'm so sorry.
Hey, Bill, if I could chime in just on Jim's question. Sorry, and about the referral sources. So you alluded to it. So I think the biggest thing is, from a palliative perspective, is educating the referral sources on what palliative care should be. And, as Bill said, sometimes we cast too large of a net, and we're bringing patients in that really aren't, a year out. I've seen organizations that they're looking to capture patients 3 years out. That's way too long. So I think it's being really, really clear on what you're willing to admit, and then setting that standard within your organization of who you're willing to accept, and also educating your referral sources on what palliative looks like for your organization, because it is different in every place. But that relationship with your referral sources is really, really clear. We've seen a big wave, especially of your palliative that are connected to hospitals, of getting a lot of pain management patients. And these patients really aren't hospice eligible. And so you've got to be very, very forward and upfront on what you are going to accept from a palliative perspective to preserve that relationship.
Thank you, Shane. And I'm going to piggyback on that for just a minute. I know that you are missionally minded people, but there are an infinite number of needs out there. And pain management is one of those needs, but you can't help them all. We don't have the resources to help them all. So we have to be so careful that we don't try to take everyone. Thank you so much, Shane. Thank you. Here's a good one. Do you run your palliative out of the home health care prior to conversion as long as they meet the hospice COPs? You don't see a whole lot of palliative programs in home health and hospice combinations. First of all, you don't see that. It is a good place to forgive the term. It's a good place to park people sometimes if they're going to be hospice eligible coming out of home health. All right, if they're not quite ready for hospice. But if they're ready for hospice, come in for your home health, put them on hospice. All right, clinics can help. Did I mention that clinics can help? It helps the number of visits that your providers can do in a day. Measures that matter. These are things that I very much want you to measure every week or every month. First, by clinician, billable visits. I want you to know how many billable visits or units, because as you know, some visits can count for two units per week. You can't live a palliative program where you're just getting 10, 12 billable visits or units per week. It's not going to happen. That's why it must be measured so that you know what you're getting. Second, the second bullet is probably the single most effective measure for both hospice and palliative care when it comes to activity, sometimes called productivity. you want to know the percent of hours worked that are billable. So, and on the hospice side, that's the percent of hours worked spent with patients. So on the palliative side, it's the percent of hours worked that are billable. Not hard. Here's the equation. Take the hours that are billable. That's on top. Okay. Divided by the number of hours the clinician worked. Guys, you want about 50%. You want at least 50%. All right. Your clinicians need to be spending about 50% of their time on billable visits, or at least with patients, at the very least. Collectible revenue. I want you to know what you're getting from each of your clinicians this monthly. Collectible revenue monthly. Conversions to hospice. Yes, you're going to find that some clinicians are better at it than others. And you want to know which ones. Measure this monthly conversions to hospice from whoever the case person is. All right. So a lot of questions coming in, and I will let me get this paragraph, then I'll jump to that. Program measure. Every month, I want you to compare this: the length of stay of hospice patients referred by Palliative to the length of stay of hospice patients referred by other referral sources. Don't include your IPU. You need to know that, because if your length of stay for patients from the Palliative program is the same or even less, that's not a healthy Palliative program. That's not a good Palliative program. You got to measure that, guys. We're needing that to be a significant length of stay more. Okay, I think we're up to a lot of questions here. Let me try to hit a couple of them that I see now. Are there insurance programs out there that actually reimburse for palliative care services? Oh, Simona, what a great question. Can I answer this way? Okay, last year I spent a lot of time with a hospice that needed some help in Hawaii. I got to make 6 trips to Hawaii last year. But between yawns, here's what happened. Hawaii started paying for palliative care. And all the hospitals, whoa, they're paying for palliative care now. We can get this program in motion. Well, where I was working in a rather remote part of one of the large islands, the hospital, as soon as the state started paying for palliative care, well, the hospital started their own palliative program. So the referrals that we started getting from that hospital, all of a sudden they were brink of death patients. We were getting them later rather than earlier. So friends, those of you wondering about when their people are going to start paying for palliative care, be careful what you wish for. Be careful what you wish for. Then again, just 2 weeks ago, Simona, I was working with this hospice in California, and the medical director got a call from one of the big insurance agencies that's part of Medi-Cal. And he's saying, we need, because their palliative program wasn't very good, we need some help. We would like to contract with you to do some palliative care for us. And we're thinking, well, yeah, if we can get some terms right, we want to do that. We want to do that. Not sure how that's going to shake out yet, but a good friend of mine said, ask for what you want. We're asking to embed a patient in their insurance company to look in their records, trying to identify palliative eligible patients, hospice eligible patients. Will we get that? Who can know? Probably not, but we asked. Okay. Are you setting a prognosis for patients? Are you admitting, for example, less than 12 or 24 months? I don't have a good answer for that. Cost accountant, guys, cost accountant. So for that one, I don't know. But if I know that someone has a terminal diagnosis, I'm bringing them in any way that I can get them in. Anyway, palliative or whatever. Helene.
Hey, Bill, I'll add to that question as well.
Yeah.
And so I think, what we've got at other agencies to do is really just have a very defined acuity range for your patients. And, your staffing and your visit frequency should be based on the acuity of what those patients are. So oftentimes there's a cookie cutter visit frequency based on a patient's need. And it might be, okay, we see him once a month. Well, as that patient declines and gets closer to needing hospice transition, we should be increasing our frequency of visit, frequency of touch. Maybe it's virtually, maybe it's a home visit. But I think that's where I see a lot of gaps in palliative care programs is they really aren't treating each patient individually, but they have a standard cookie cutter visit frequency versus looking at that acuity and, you know, having a cadence of communication around decline with these patients. As Bill talks earlier, you know, when you right size, having the right size census, which is typically smaller than what you have, is going to allow you to go a little bit deeper with those patients, have more meaningful discussion, and truly provide better quality of care at the end of the day.
Thank you.
And I know there's a lot of questions here, and we've got a lot of good content here.
Yeah.
We may hold some of these to the end of the presentation, and then if we're not able to get to your question, we will certainly send you individual messages.
Yes, but I have to take Helene's. All right, because I haven't seen Helene in over a year, and I need to address Helene. Helene's question is, we did open a palliative clinic. Any strategies to decrease the no-show rate? I'm going to give you one, and it'll get down when I get to you're not going to, some of you aren't going to buy what I'm about to say, the volunteer section. When I get to the volunteer section, okay, that is a strategy that I want you to use. Helene, okay? All right. Let me scoot along, and thank you for the prod, Shane. All right. Okay. I want to show you a staffing tool. And this will go a little bit towards someone's question. I believe it was Samta. I'm going to share my screen. Now, each of you can get this. Let's see. Share. All right, tell me that you see my beautiful spreadsheet. Shane, do you see my spreadsheet?
We are seeing the media player right now.
You are seeing the media player. Okay,
Yeah.
let me do better. Okay, now you're seeing it. Now you're seeing it. All right, this particular spreadsheet is something I want you to use. You can have as part of the resources. I want you to use, it's kind of a staffing calculator. It's a way for you to see the net expense to the hospice target. Remember I said you can't lose more than 2%. That's the bill line. You can't lose more than that. All right. Now, there's a place to start. You put in your projected hospice net patient revenue for that period. Let's call it a month. Got to start with the hospice piece so you know what your target amount is. And if you have a grant, put it in here. Most people don't. I'm going to take that piece out. Then I want to know what the benefits percentage. As a percent of wages, what are your benefits? Type them in here. If you don't know what to type in 20. Loss limit, the bill limit is 2. All right, some of you might have 1, but that's enough. For some of you who get more advanced, you don't have to use this part. Some of you might want to put in some special rates you get from other payers. I think this did come from Hawaii. And some of you will recognize some of these codes here, and I fill them in here. You don't have to use these 2 pieces to make the staffing tool work. We'll click over here. This other payer was coming from this right here. Most people don't have that. So I'm going to take it out. This piece here, this fee for service, most of you do have that. That's the dollars that you expect to collect. Did you hear that word? Collect from visits that you make. If you want to use this calculator here, if you want to put in your projected visits there, that's fine. And if you need help doing it, call me. I will help you do that. But if you don't, and you know, well, each month we do about $12,000. Type it in. That's all you have to do. Type it in. Then, at some point, we need to put in our people. Now, I'm going to take in all these hours right now because we had a question come in from Samta. She says she has a doctor, and I don't know what her doctor's pay rate is. Don't know. I'm just guessing. Let's just throw it in at 100. How much time is this doctor? I think it made it sound like your doc was full time. I'm going to put that in here. It's going to calculate the pay with benefits for that physician. And I think you said you had a part-time NP. Part-time NP. We'll leave this as, we'll call it a $60 an hour NP. Some of you are saying, no way. All right. So, okay, I'll push that up. I'll push that. Depends on where you are. And hours, I think you said it was a 0.3, right, Samta? So it was equals 0.3 times 173. By the way, 173 is full-time for 1 month. And it's got the amount that we're going to pay for this particular person. And look, lo and behold, Samta, I'm using the numbers that I think you gave me. If $12,000 are your collections for a month, you're going to lose, not including under expenses yet, you're going to lose 1.59% of what? Net patient revenue. Hospice net patient revenue. You have some headroom there, Samta. Suppose you want a coordinator. Suppose you want a coordinator to help keep everything straight, because does your doctor really want to keep everything straight? Probably not. So let's say that you can find a $35 an hour coordinator to work for you, let's say 173 hours. And I don't know if you can do that. This is 2.44%, and this is your target. Samta, I'm going to give you a qualified no on that. Unless equals times 0.5. If we can put your coordinator, Samta, in it just half time, look, my friend, you're nailing it. You're nailing it. All right. So how can you give yourself more headroom? How can you give yourself more headroom? More fee for service. That's helpful. That's a big deal. Okay. A grant. Oh, that's nice. Who wouldn't want that? Let me tell you another way to give yourself more headroom. Do you remember way back here when we put in hospice net patient revenue? The more patients you convert to hospice, and the sooner you convert them, the bigger this number is going to be. And the bigger this number is, I'll just put in a bigger number. What is that? 800, that's a bunch. I'm going to put in that number. We jump over here, and bang, you've given yourself a whole lot more headroom. So if you need some help with this tool, let me know. Just email me, okay? And I haven't made a video yet to put on the website of how to do this, but I shall. Let me show you something else you need. I want you to have a regular dashboard just like this for each of the people in your palliative program. Let's see, and the staffing tool, I took some hours out here, and that's skewing my numbers. But this is the activity. Call this your productivity dashboard if you like. It's got the person's name and their discipline, total billable units for the month, total collectible revenue for the month, and it's going to do some calculations for you. The percent of hours worked in billable time. We talked about this, did we not? We talked about that. That's important. Collectible revenue per revenue unit. I think that's useful information for you for that period. So look at this. Look at providing these. Now, you won't be able to, from this tool, duplicate this. Now, I was able to do it myself for this particular agency. That's because I was able to paste in their EMR information, their Paycom information. Yours is going to be arranged differently, so it'll have to be, consider this piece a guide for you, okay? All right, questions about this tool, and I'm unable to read any response if Samta told me that I got this wrong, but I'm hoping you kind of understand it. I'm going to have to go back to the stop sharing piece so that I can see any questions about the tool. All right. I'm going to give you, and I'll look at questions later because I don't want to miss some of these. Guys, this is the money slide. This is the one that I want you to make changes and moves in your organization right now. Look at this top blue board here. We're looking for earlier warning of rapid decline. That's what this is about. Moves that drive the business, relationships with external partners. Obviously, you're already doing this with hospitals, hope so. And some of us are getting to do this in certain contexts with insurance companies, all right? Well, let's look at this other piece. I've headed at volunteers, and I know you use in your hospices, you use your volunteers over to fundraising. You use your volunteers to work in the office. I get that. Let's put them to a, dare I say, higher use. All right, some patients, especially when they come from hospitals, they slip through our palliative fingers. We don't get them. We go in and say, we make the pitch for palliative, and they say, oh, not yet. Well, we've got their information. Our volunteers are going to call them weekly. And they're going to be asking, they're not saying, are you ready yet? No. Let's ask the right question. They're asking about pain. They're asking about the diagnosis. They're asking about symptom management. And when they start hearing this, when they start hearing these things, they start to say, we can help you with that. I'm going to ask Emily from Palliative to call you. Is that okay? You see how we can leverage our volunteers to not let these people slip through the cracks? Because you know where the cracks they're slipping through? Your competitor. That's where they're going. That's who's going to pick them up. Second, and I believe this to be one of the most valuable things that you can do for existing palliative care patients. A volunteer calls, and Helene, I think this is answering your question about no-shows too. I don't have a solution, but it's an answer. A volunteer calls each of our palliative patients weekly. They're already on service. They may or may not be getting a visit that week. We don't know. But a volunteer is going to call each of these palliative patients weekly, asking about their pain, asking about symptoms related to that diagnosis. They're fishing, guys. They're fishing, looking for that earlier warning of rapid decline. And let me give you one more. After every visit, after every provider visit, that clinician either texts or contacts the palliative leader with a quick update on potential hospice eligibility. Friends, let me tell you why this is. We're not saying our people don't know what they're doing. They do. What we are saying is we want to keep eligibility in the forefront of their mind at all times. We want them to remember their primary mission. This person's eligible, we're moving them out because they get so much more care out of hospice, because we can do a better job of care through hospice. Does that make sense? Okay. All right. Okay. So, Shane adds one more to this, but I didn't have room to put it here, Shane. Shane likes to see a weekly meeting between the clinical director and the palliative leader, comparing notes, looking at these palliative patients. So the clinical director of the hospice is actually looking at these patients saying, why isn't that person with us yet? Why don't we have that person yet? And there's value there, Shane. And I'm sorry, I left it off because I didn't have room. Okay.
Yeah, no, I mean, you're spot on. It's that, keeping it in the forefront, your highest acuity patients should be talked about weekly. What is our plan to advance them to hospice? And so many times we don't see palliative and hospice communicating together because they've become their own separate silos. And so, this is a perfect opportunity to have a weekly touch base about those high acuity patients that they are ready. It also helps the hospice prepare and be ready to have someone available to admit ASAP. Mm-hmm. One other thing I'll just add to this too, Bill, and it even starts at the beginning, and I mentioned it earlier in my piece, but with the referral process is, when a referral is coming through intake, screening that patient for palliative, they should be screened for hospice eligibility upon that first referral. Yes. Because so many times, and I saw someone made a comment about, the over prognostication and getting patients way too late. Well, that's on us as an agency to identify eligibility and get them to the right team the soonest. And so often a patient comes to palliative, it might take us a week or two to get out there to see them or to get their visit scheduled. Well, we should be seeing that patient within 24 hours, if at all possible. How do we have some sort of screening process within 24 hours of all new referrals to make sure we're not missing a potential hospice eligible patient? And that's what happens so often is, we slow down the process by not having good systems in place.
Lovely. So I'm going to answer a couple more questions, and some of them are better for you than for me, Shane, but I want to talk about Emily Hunt. What qualifications training do the volunteers have to ask these questions? Really good question. Really good question. I've done this with volunteers. I've done this with clinicians, and I give them just a list of questions to ask. I just want people with nice phone skills, and I know that you'll do more than that. I know you will. Okay, and you're thinking that's too simplistic, Bill. Take it as far as you want. I want people who have good phone skills, are nice, who can smile through the phone, and get people to talk about their illness. That's really all I want, because I'm having to ask questions. You can't let them give any advice. You know that. We just need to ask some questions. All right. Let's see. Oh my goodness. How do you value David Lavelle? You asked the question of the day. Let me open it. Guys, I'm going to share my screen again, and I'm sorry, and I have to bring up something first. Program contribution. All right, I've been working on this. It's not complete. Are you seeing a slide that says program contribution? You're not, are you? Yes, you are. Yes, you are.
Yes.
Don't look at this stuff. I'm not finished with it yet. Look at these things. This is what I want you to do. The program. First, calculate the length of stay of your non-palliative referred patients. Calculate that. Then calculate the length of stay of your palliative referred patients. All right. Multiply the difference, and let's hope it's something like 30, 40 days. Let's hope it's more than that. But suppose it's 30 days. You're going to multiply that times your composite rate, which let's say is $200 a day, hospice rate. And then you're going to multiply that, okay, times the number of patients you have on palliative. That's the extra dollars your palliative program is giving you. Now, you spend half those dollars on care, so cut that in half. Cut that in half, and now you're going to know the absolute value of your program. Now, there's not a way in the world that anybody caught that. Oh, but we're recording this. And if I can, I'm pretty sure that once I figure out how to stop sharing my screen, I'm not sharing anymore, right? Okay. When I get all your emails, I can send you this. I can send you this particular thing so that you will know how to value your palliative program. Let me make the tool for it first. Let me make it pretty first before I send it to you, okay? All right. That's a great question, David Lavelle. Good. Gerald, weekly huddle, smart. Standard script for volunteers. I'm not the guy to write it, but I just want to know a couple of things. I want to know about is the diagnosis progressing? How about what's happening with your pain? Okay. There was a good one here.
Yeah, Bill, there's one from Natalie.
Yeah, would you take that one, Shane?
Yep, absolutely. So the question is, we are a company with two lines of business, home health and hospice. We're looking to partner with an NP-owned clinic practice to do the palliative business to help transition those to hospice when eligible. Any suggestions on how to make this successful? So there's a lot to unpack in that question. I think one is you do need to be careful, when you're identifying what it is, because sometimes our referral sources have a perspective of what palliative care is, and it's the Part B model versus what it looks like you're doing, which is really, keeping them on home health, having kind of an in-between to help manage patients until they get over to hospice. So I think the key here, and all the tools we talked about could still be utilized. It's like, are we getting the right patients into the funnel? Are we seeing them with the right frequency? And then are we getting them transitioned over to hospice timely? So I think, going from where you have really 2 service lines to now 3 service lines that are touching these patients, that communication and that process is just going to have to be very well defined to make sure the patients are getting, touched with the right frequency.
Yeah.
Hope that answers your question.
I think I'd also look at how are this NP-owned clinic practice, how are they compensated? I mean, is it to their advantage to send patients to you? or is it not? Oh, Patrice, what recommendations do you have for reaching patients in underserved areas who are resistant to discussions about palliative care transition to hospice despite eligibility? It's a big challenge for one of the counties that you serve, and it does skew your data. It does. Patrice, I'm with you there. I live in the mountains of Western North Carolina, and we have a lot of people like that. So recommendations, I don't have specific logical. I don't have logic, because logic doesn't work with we mountain people, okay? Feelings work with we mountain people, all right? So I wish I could give you more. Shane, got anything you can help with that?
Yeah, I mean, I think it's just, making sure that your palliative care doesn't become like a primary care physician for people. And I see that happen a lot is, we start helping these folks who really need the support because they are underserved, but then they start utilizing, if you're in a clinic model, using it more as a primary care model versus really being palliative. And so I think, what I've seen work at times is maybe setting like pop-up clinics in some of these markets where, you're there once a week and maybe it's at a senior center, or you're doing things from that perspective to create visits. But it's trying to get in the community and really at the end of the day, providing solid education on what hospice is, what palliative care is. So, you can take the lead from a sales perspective of getting your team out and just doing education there. One other question I do want to ask, because Angela asked, do we have a resource on defining acuity?
Yeah, that's a good one.
So, there are some tools out there. I mentioned it earlier, it's making your leader needs to be really, really astute in what does hospice eligibility look like. And, I see so many palliative teams, they don't even use the FAST scale. They aren't using, PPS. I mean, those are two that you can implement immediately. And like, where do these patients land on those scales? You also need to look at, what does past hospitalizations look like? Has this patient been in and out of the hospital, numerous times within the last, 5 months, 3 months? So, you can build your own acuity scale, but, those things like, the PPS FAST, as well as, recent hospitalizations, all of those are good starting points to see where people land.
Mm-hmm. Brian, I'm going to take a quick run at yours because it's not going to be a satisfactory answer. Let's say you have a standalone palliative agency owned by the same owner as the hospice agency. Are the hospice and palliative agencies allowed to create a contract for the hospice to? Man, you talk to a lawyer on that one. All right. I want you to be solid on that one, because I don't want to give wrong information. That's scary. Melissa Heron, what's your opinion on shared NPs in palliative care and hospice? I don't have a problem with them at all. I do not. If you have a small hospice, you don't have a choice. But I hear what you're saying. They're getting pulled away to do face-to-faces. And I don't understand the pulled away to do face-to-faces. That's coming. All right. That's something that you can schedule pretty in advance. That's coming up. But eligibility visits for hospice, I understand. I hear what you're saying. Chantal, you're right. Okay. She's saying that similar to volunteers, nurses' aides are low-cost alternatives, providing a much-needed service and with eyes on the patient. Does this, however, tend to set up spending too much money on palliative patients in order to prevent conversion to hospice because patients are already getting the services they need? The money part, the staffing tool is going to solve for you, Chantal. Look at the staffing tool. It'll always give you the right answer. All right, do that. If you don't feel good about volunteers making these calls, aides are fine. In California, they now have health. Oh goodness, they have a term for it. They have trained people healthcare type people that are fairly low cost that can help you with these sorts of things. How many billable visits are good in a day? And I want 4. Unless there's a clinic, then I want more. I want at least 4. I don't think I like to go by week. I like to say 20 a week because there's sometimes when, you know, you can't, but I want at least that. I don't see why we couldn't get that. But I want good quality visits. I want quality visits, time with the patients. Oh, let's see. What else are you seeing, Shane? There's more questions here than I can.
Yeah. Well, there's
address.
one. Here's a good one from Vanessa. How can hospice palliative programs leverage partnerships with ACOs to increase referrals and length of stay? I mean, that's a great question. And, you know, sadly, and this is just the reality of our business, I feel sometimes that, you know, some of your health systems and other organizations don't always see the value of hospice or palliative care in our ability to impact rehospitalizations, impact cost. So I do think a lot of that is getting in front of the right people to show that value. Again, a good part of why we have this program is there's a lot of palliative programs out there that aren't showing their value. They're just getting bigger and bigger. They're not impacting patient care as well as they could. They're not getting patients over to hospice as well. And so it's really hard to come back with a great story to say, hey, look how we impacted cost with this patient. You know, many times they're ending back up in the hospital when they go to palliative care. So that's where we've got to get really good as an industry of showing our value. And a lot of the tools we shared today will help with that.
Excellent. Angela, you have a really good question. How much more do the palliative care days need to be more than the average length of stay of hospice? You know, in most of the hospices I work with, I'm going to ask for about 30. I'm going to ask for that and see where I get. But I'm thinking in your organization, you probably already have a pretty good hospice length of stay. So I'm not sure that your palliative program is going to be quite delivering at that same length of stay. Does that make sense, Angela? I don't want to shut this down. I'm looking for one more. Paula, just one question about payment. There are things we can get paid for palliative. Nurse practitioners, certain visits can be paid for. Social worker, of course, physicians. Not much for RN, a little bit. Okay, so there are ways that we can get paid. It's not really through hospice, just straight through Medicare Part B. So I think that we've covered most of the questions. So Holly, I'm going to throw it back at you, my friend.
Yeah, you definitely got through a lot. I love that we have so many questions. I think you're definitely speaking to a topic that is top of mind. Palliative care sustainability is always a question that we get from both Hospice News and Palliative Care News readers. So timely, relevant, engaging, love to see it. I also admire you both for trying to tackle this topic as well. As you can tell by the questions that we're getting, it's no easy feat. So we just thank everyone for attending. We thank both Data Shark and Chat for sponsoring this. Again, you can catch this recording on our virtual site. You know, registrants should get an emailed link to it as well. I think if we have any questions that we can kind of decipher out, you know, I'm sure that Data Sharks and Chat will try to address those as well going forward. Yep, I'm getting nods from from Shane. So, all right, you guys, thank you so much for walking us through this. Stay tuned for more from Hospice News, but that's it for now.
Okay. Thank you all.
Thanks.